Dinakar sir, Patricia sir.
Hello, how are you?
Fine sir.
Ah,
Fine, sir.
Prashant.
So
Both are
yes,
online.
sir.
Dr. Arun and as well as hello.
Dr. Gayatri. Yes sir. Yes sir. Yes sir. Both the speaker
Dr.
online.
Arun is online. Okay.
Yeah. We're going to start the session.
Okay. Well, I welcome for both the speakers on behalf of KNF. Let us start the activities.
Okay.
I welcome Dr. Arun as well as other fellows.
Yeah. Dr. Dinakar sir.
Ha, Prashant, start. See that. Everybody, please tell them to log in. Don't restrict anybody. Okay, number one, and allow them to ask the questions. Let the program, because only two speakers are there, let them take their own time. In case if anything is there, let both the speakers, let them go little slow, so that all the people should understand, because they are not dealing with only research people or only neonatologists. They're all dealing with all the doctors. So let the speakers go slow. Okay, dear. Please.
Yeah. One second.
Prashant,
Yes sir. Yes sir. One second.
all our joint secretaries are there. Dr. Sidhu, Dr. Raghavendra,
One second. Asha.
Sidhu, Raghavendra, Sohail Ambi, Leslie. Dr. Leslie, Dr. Sidhu, Sohail Ambi, all the EB members.
Yes sir. Yes sir. Yes sir. They've all joined. Yeah.
Join, no? Everybody join. Hi, Sidhu.
Yes sir. Yes sir. Because they cannot unmute themselves. Sidhu is not joined, but they cannot unmute. We'll start the session, sir.
Yes, sir.
So before that, I request Dr. Asha ma'am, Asha Venkappa ma'am. Dr. Asha Venkappa ma'am. So our own Karnataka professor and director of Indira Gandhi Institute of Child Health, Dr. Asha Venkappa ma'am, she with our colleague Dr. Pavitra, they have written a book by name Our Companion. It's a compilation of protocols from the various sources. So thank you very much for writing this book and making us feel proud. So people who are interested, they can get this from this particular address. You can. This is the thing. Please save it as a screenshot if you need it. We are telling it on behalf of NNF Karnataka. We are proud that our Karnataka professor and director of the Institute, she has written. We are very proud of you, ma'am. Thank you very much for that. So, without wasting much of time, I would request.
Arun Kumar Desai not able to join, it seems.
One second.
Dr. Ashwin join.
Arun Kumar Desai.
1 second. Yes, sir. He went out with the internet problem.
Dinakar.
Sir.
Hello,
sir.
Hello, sir. Ashwin join already?
Make him co-host.
Yes, sir. Yes, sir.
Okay, fine.
Yeah. So we're going to start the session now, sir. You'll be able to do it. 1 second.
Okay.
Arun, sir. Arun, sir.
Yeah, I can hear you, but I can't see my.
Yeah, we can see you, sir. Please start sharing, sir. We have made you co-host. You can start sharing your slide. So,
can you see my slide?
Yes, sir. Yes, sir. I can see your slide. Welcome to the welcome on behalf of NNF Karnataka. Thank you very much for joining and accepting our request to be a speaker. Dr. Arun Kumar Desai, sir, is a former professor and head of the department, Belagavi Institute of Medical Science. Thank you very much. Over to you, sir. We'll be talking on Hydrops Fetalis, and followed by this session, Dr. Gayatri. She's an assistant professor at JJ Medical College, Davangere. This today's session will be moderated by Dr. Shriyan. Over to you, Arun sir. Please take over the session.
Thank you, Dr. Prashant Gowda. At the outset, I wish to thank NNF Karnataka for inviting me today to talk on Hydrops Fetalis. My special thanks to Dr. Kutresh, Dr. Kishore Kumar, Dr. Dinakar, yourself, and all in NNF. Today's talk is on Hydrops Fetalis. I'll be covering this topic on the following headings. First, the definition, incidence, the types of hydrops, pathogenesis, the various etiologies, the clinical presentation, relevant investigations, and management. First, what is Hydrops Fetalis? This is a condition in which the fetus presents with abnormal fluid collection in at least two of the following. One, there is skin edema more than 5 millimeters. The fetus can present with ascites, pleural effusion, or pericardial effusion. In addition, the mother may be having polyhydramnios and with thickened placenta more than 6 centimeters. Let us look into the history of hydrops. Hydrops has been well known to mankind. In fact, Hippocrates in 400 BC described Hydrops Fetalis. Later, in 1609, a French midwife reported hydrops in a set of twins. In 1982, Valentine first discovered that there were multiple etiologies for hydrops. In 1940, Landestein discovered the RS antigen. And in 1941, Levin et al. Established correlations between an RS negative mother and an RS positive fetus when the antibodies cause RBC hemolysis leading to hydrops. In 1943, Potter was the first to distinguish between hydrops because of erythroblastoma fetalis and hydrops because secondary to non-immune hydrops fetalis. Let us look at the incidence. The incidence of hydrops varies from region to region. It varies because of etiology, the ethnic population, and most important, the availability of investigations, sophisticated investigations to diagnose hydrops. The accurate estimate of the incidence is often very difficult because many a case of hydrops antenatally cannot be, even before they are detected, they result in intrauterine death. And in some cases, there is even spontaneous resolution. So the exact incidence is very difficult to assess. The reported incidences from various centers can vary from 6 per 1,000 in a high-risk referral unit in the UK. And in the same country, another center reports an incidence of about 1 per 4,000 pregnancies. The other incidences reported vary from 6 per 1,000 to 1.3 per 1,000 to 1 per 1,700 pregnancies. Hydrops are basically of two varieties. The more well-known one is the immune hydrops, and maybe the less well-known one is non-immune hydrops. Immune hydrops, till a few decades ago, was the most common cause for hydrops. The pathogenesis of immune hydrops has been drilled into us from our undergraduate days. So I will not go into the detail. Even very recently on the webinar on neonatal anemia, this was discussed in detail. But what I'd like to highlight here is that which was once a very common cause for hydrops, now accounts only for 10 to 20% of the cases of hydrops. So the incidence is rapidly dropping. The reason for the drop in the incidence of immune hydrops is basically because of widespread availability of anti-D. Another thing what I'd like to highlight here, the cause in immune hydrops is well defined. There is a very well established diagnostic approach and a therapeutic approach to immune hydrops. And if managed well, both antenatally and posteriorly, these hydropic fetuses can have a good prognosis. The same is not true for non-immune hydrops, which presently is the predominant cause for hydrops. And non-immune hydrops today, in many series, accounts for more than 80 to 90% of the cases. So what is non-immune hydrops? Hydrops occurring in the fetus because of any cause other than immune. In non-immune hydrops, there is no circulating antibody to any red cell antigen. In general, non-immune hydrops is caused by failure of the interstitial fluid to return to the venous system. It can result from an array of disorders, either occurring in the fetus or in the umbilical cord or in the placenta, that leads to derangement of the fluid homeostasis. And because it occurs because of a wide range of abnormalities in the fetal organs, there is no common mechanism which is responsible for hydrops. Non-immune hydrops may be due to a cardiac failure, maybe because of this return, can be of obstruction to the normal lymphatic flow, or it could be because of increased capillary permeability, as can occur in sepsis, and decreased colloid or cortical osmotic, especially when liver is involved. This can explain this of non-immune hydrops in various conditions. Hydrops because of inborn errors of metabolism or hematological disorders or infections, all of which can involve the liver, leading to liver failure. There is low iron production, and that leads to low oncotic pressure, because of which fluid escapes into the interstitial space, leads to non-immune hydrops. In cardiovascular disorders with congestive cardiac failure or hematological disorders associated with severe anemia, or when there is an obstruction to the venous return, all of which result in heart failure. Heart failure will result in high central venous pressure, and because of the increased static pressure, escapes into space, leading to non-immune hydrops. In placental disorders and urinary outflow obstructions or disorders, there is overload. This leads to heart failure, and again, because of the same reasons, this leads to non-immune hydrops. In the cases of lymphatic dysplasias, there's reduced lymph flow, and because of which fluid from the interstitial space can't get the lymphatic flow, and they accumulate in the interstitial space, resulting in hydrops. If you look, this is a pie diagram representing the various causes of hydrops. There are three major causes. The one shaded in yellow reflects the causes because of cardiovascular condition. In the dark blue is the one because of chromosomal disorders, and the light blue, which is a major cause, which is because of idiopathic conditions, meaning at the availability of investigations at your command in more than 25 to 30% of the cases, you may not be able to establish the exact cause of hydrops. All the remaining conditions account for only about 25 to 30% cases for us. Let us look more detailed into the causes of hydrops. For cardiac causes, you can have still anomalies, such as Epstein's anomalies, atresia, coarctation of aorta, hypoplastic left heart, AV canal defects, sided obstructive lesions, premature closure of the foramen node. Congestive cardiac failure could also be because of cardiomyopathy.
Sir, Arun sir.
Intracardiac tumors.
Dr.
Yes.
Arun sir. Sir, can you speak little
Yes.
louder? Can you speak little louder? We are getting feedback that the voice is not very clear. Can you speak little louder, sir?
Can you hear me now?
Yes, sir. Yes, sir. Little more louder.
Little more louder.
Yes, sir. Yes, sir.
Should I come closer?
Yes, sir. Yes,
Can you
sir.
hear me
That
now?
will help. Yes, yes, sir.
Yeah.
Yes, sir. Yes, sir.
So after the structural anomalies involving the cardia, you can have cardiomyopathy in various conditions, resulting in congestive cardiac failure. You can also have intracardiac tumors as commonly associated with tuberous sclerosis. And then there can be cardia without structural anomalies, as in the case of cardiac arrhythmias, as seen with ventricular tachycardia, flutter, heart block, WPW syndromes. The next common cause for non-human hydrops is chromosomal anomalies, commonly associated with trisomies 13, 18, and 21, also commonly associated with Turner syndrome or Noonan syndromes and these other conditions. Fetal anemia will result in congestive cardiac failure, resulting in hydrops. Common among them are alpha thalassemias, associated parvovirus infections, those associated with fetal hemorrhages, and because of G6PD deficiencies. Infections associated with hydrops are the POTS group of infections. Then they can be the parvovirus infection, herpes infection, varicella infection, viral infections, influenza, and listeria. The thoracic abnormalities associated with hydrops, the most common one, congenital cystic adenomatous malformation of the lung. There can be chylothorax in the lung, diaphragmatic hernia, and mediastinal tumors. All can present with hydrops. Hydrops can occur in twinning, in monochorionic twins, where the recipient can become hydropic because of high output media. The recipient, the donor, can become severely anemic. Fetal tumors, such as the sacrococcygeal teratomas, hemangiomas, fetal adrenal and neuroblastomas, and placental tumors can also present with hydrops. Renal disorders, fetal renal disorders, such as venous nephrosis, hypoplastic kidneys, polycystic kidneys, renal vein thrombosis, bladder outlet obstruction, and dysplasia can all present with hydrops. Neurological malformations can be a rare cause of hydrops. They include encephalocele, proencephalopathy, absent corpus callosum, intracranial hemorrhages, and vein of Gannon aneurysms. Skeletal dysplasias associated with hydrops are achondroplasias, osteogenesis imperfecta, osteochondropathy, thanatophoric deform, and chondrodysplasias. Other miscellaneous causes leading to hydrops are cystic hygromas, inheritable disorders of metabolism, and maternal thyroid diseases. Having known these causes for hydrops, The one thumb rule is that if in non-human hydrops, if it presents before 24 weeks of pregnancy, it is usually associated with a chromosomal abnormality and having very poor prognosis. If hydrops present after 24 weeks, they are usually because of structural anomalies involving the lung. Many cardiac structural defects are commonly associated with karyotypic abnormalities, and they carry a very poor prognosis. The example is coarctation of the aorta with Turner syndrome and AV canal malformation commonly associated with Down syndrome. The one cardiac condition with good prognosis is supraventricular tachycardia. These are rarely associated with any structural anomalies, and they can be easily detected by cardiography. The good thing about them is they're amenable to therapy, both in utero and ex utero. Therefore, apart from supraventricular tachycardia, most cardiac lesions with hydrops lead to in utero or early neonatal deaths. Congenital heart blocks can also present with hydrops. They can occur in 60% of the pregnancies complicated by maternal collagen disease, especially that with hydrops. The heart block is because the maternal IgG antinuclear antibodies cross the placenta and destroy the fetal collagen in the conducting bundle, leading to heart blocks. Chromosomal anomalies are a frequent cause of non-immune hydrops. Common among them are Turner syndrome, and these are commonly associated with cystic hygromas in the neck or in the abdomen or in thoracic regions. The other chromosomal anomalies, as already previously told by me, are trisomies 13, 18, and 21. Whenever chromosomal anomalies is a cause for hydrops, it is associated with very poor prognosis because majority of them are associated with structural, functional, or metabolic defects. This is an example of a fetus presenting with cystic hygroma. Hematological condition which lead to severe anemia can result in hydrops. Common among them, especially in Southeast Asia, is homozygous alpha thalassemia. Actually, in one study, this was the cause for hydrops in more than 86% of the cases in this study. The other causes for severe fetal anemias is hydrops resulting from fetal hemorrhage, and this can occur in the intracranial area or because of a rupture of arteriovenous malformation. Severe fetal anemias can also be seen in sacrococcygeal teratomas. Feto-maternal hemorrhages, as can occur in abruptio placenta or in placental tumors such as in chorioangiomas, can also present with severe anemia leading to hydrops. Pulmonary conditions. The most common of them is congenital cystic adenomatous malformation of the lung. This is the most common thoracic lesion associated with hydrops. What are they? They are basically abnormal capillary alveolar development, and this results in a functionless large cyst forming a large lung mass, which is a space-occupying lesion in the chest. This space-occupying lesion compresses on the developing lung, not allowing it to grow, resulting in hypoplastic lungs. They also cause pressure and shifting of the mediastinum they and compress the heart, resulting in obstruction to cardiac venous return. This causes central venous hypertension, and this will lead to hydrops in severe cases. All pulmonary space-occupying lesions have the same pathogenesis. The same is seen with congenital diaphragmatic hernia. As you can see in this picture, a large part of the intestine, the liver, is in the chest, and this compresses on the mediastinum and on the lung, leading to hypoplastic lung and pressure on the cardia, resulting in hydrops. Torch group of intrauterine infection: syphilis, Coxsackie virus, and parvovirus infection are associated with hydrops. How do they cause hydrops? They usually result in fetal anemia because of lysis of the red cells or the suppression of erythropoiesis and myelopoiesis. Many intrauterine infections involve the heart, leading to myocarditis and congestive cardiac failure. They can also involve the liver, leading to liver cell failure, and both of which contribute to fetal hydrops. Let us look at parvovirus infection. This is very interesting because it is emerging as one of the leading cause for non-immune hydrops. In fact, many studies report 1/3 of the cases because of parvovirus B19 infection. They cause hydrops because they attack bone marrow erythropoietic stem cells, leading to severe anemia from red cell aplastic crisis. The silver lining to a parvovirus infection is that in 1/3 of them, you can expect spontaneous recovery without any treatment. And the remaining fetuses, you may be able to carry till term by repeated in utero blood transfusions. And subsequently, when these babies are delivered, they have good long-term prognosis. Having looked at all these etiologies for hydrops, let us look at how we approach the evaluation in these conditions. Now it is amply clear that non-immune hydrops can result from a large number of causes, needing extensive clinical workup. You can start this by evaluating the mother. In the mother, look for hereditary metabolic disorders. Look for diabetes in the mother, intrauterine infections or infections in the mother, previous history of anemia in the fetuses, and the use of any medications in the mother, especially NSAIDs, which can lead to premature closure of the ductus. Hydrops Fetalis is usually diagnosed by ultrasound evaluation. And this ultrasound evaluation in the mother can be because she's presenting with polyhydramnios or a large baby. You might have detected fetal tachycardia, or it is because she is presented with decreased fetal movements, or her antenatal screening may have been abnormal, or she may be suffering from antenatal hemorrhage. So most of the time, when she is undergoing sonographic evaluation for these conditions, hydropic fetus may be an incidental finding. When you're evaluating the mother, and if the fetus is hydropic, then the mother can suffer from a complication known as mirror syndrome. What is this? She may be presenting with edema, hypertension, and proteinuria. This condition is also known as pseudotoxemia or Ballantyne syndrome. Now, this can be quite a dangerous condition in the mother with an hydropic fetus. She can quickly deteriorate to fulminant preeclampsia and eventually having eclampsia. So much so, the corollary to this is that if the mother is presenting with severe preeclampsia or polyhydramnios very early in pregnancy, beginning at about 28 weeks, during her sonographic evaluation, you should always look for hydrops. We'll go on to investigations. We'll start by evaluating the mother's blood. The mother's blood can be tested for indirect Coombs test to exclude immune causes for hydrops. Routine blood counts with their indices can help exclude thalassemias. The blood can be tested for blood chemistry for enzyme deficiencies. The Bethke-Keil-Haulos count can evaluate the amount of feto-maternal transfusion that has taken place. PCR screening of our blood can be done for Torch group of infection and also for other infections. When hydrops is suspected, we have to do a detailed sonographic examination. So sonology is very important in evaluating the fetus. In addition, we can do a fetal echocardiography to study if there are any structural cardiac defects. Doppler blood flow studies of the uterine vessels and also the middle cerebral artery blood flow studies of the fetus is done. The middle cerebral arterial studies can tell us whether the fetus has developed significant anemia. In a sonological evaluation, the Likert volume is assessed for polyhydramnios. Then you look at the placenta. Many times it is associated with thickened placenta and echogenicity. These are some of the examples of the sonographic pictures that you can come across in hydrops. Here is a fetus presenting with pericardial effusion. This fetus is presenting with body wall edema. This hydropic fetus is presenting with fetal ascites. This fetus is presenting with hydrocele, and this can be an early marker of hydrops. Large placentas are commonly found on sonography. The next test that we undertake is amniocentesis. The amniotic fluid can be evaluated for fetal karyotyping to detect chromosomal anomalies. Amniotic fluid cultures can be done for infection. They can be tested for CMV infections. Alpha fetoprotein evaluations can be done to detect fetal anomalies. And the LS ratio evaluation is done to assess for lung maturity. For karyotyping in hydrops, you can also obtain the chorionic villus sample. When available, fluid samples from the fetus, from the fetal cavities can also be evaluated for karyotyping and other studies. A chromosomal count and karyotyping can be done these days by a technique known as FISH technique. This is fluorescent in situ hybridization technique. What is the advantage of this technique? Specific deletions and chromosomal rearrangements. And because these results are available very quickly, it is of great help in counseling the parents regarding continuation of pregnancy or termination. In the presence of a family history of inheritable metabolic disorders, you can come across recurrent hydrops. If such is the case, then you have to look for the following storage disorders. They are Gaucher's, gangliosidosis, beta-glucuronide deficiencies, or liposomal disorders, such as mucopolysaccharidosis. Both the parents can be tested for carrier status. In addition, whenever available, the fetal and the neonatal blood and urine can also be evaluated for these disorders. If the fetal tissues are available, then the histological examination should also be done in these conditions. Let us move on to the management of Hydrops Fetalis. The antepartum follow-up of the fetus depends on the gestational age of the fetus and, more important, the mother's wish regarding any intervention if they are available. In the patients whom you offer treatment for immune hydrops by repeated blood transfusion, try to carry the delivery till as close to 37 weeks as possible to avoid give time for lung maturity. If you have offered antenatal therapy, or if you are waiting for the hydrops to resolve on its own, repeated sonography every 1 to 2 weeks to know whether your treatment has been successful or whether the hydrops has resolved spaciously on its own. Always involve a neonatologist, especially if you are expecting a preterm delivery. He is the best person to advise when is the correct time to deliver and what are the possible postnatal treatments. Every time the mother visits you, don't forget to look for signs of mirror syndromes in the mother. What about antenatal fetal therapy? Yes, it is available, but not for all fetuses. Only about 20-30% of the fetus non-immune hydrops are good candidates for fetal intervention. True, even in the best equipped centers. Fetal therapy is currently offered with a reasonably good outcome in fetuses with severe fetal anemias, if they have arrhythmias, have which is accessible to treatment, in twin-to-twin transfusion, in tumors which can be excised, and miscellaneous condition associated with of a fetal therapy. Spontaneous remission of hydrops can be expected in these following conditions. Those fetuses with cardiac arrhythmias, those fetuses where there is twin-to-twin transfusion, in pulmonary sequestration, in cystic adenomatous malformation of the lung, fetuses presenting with cystic hygroma with or without Noonan syndromes, in parvovirus infections and in CMV infections, and in placental chorioangioma, and those fetuses which are presenting with ascites or pleural effusion. In some of these fetuses, there can be spontaneous remission of hydrops. Fetuses presenting anemia are the best candidates for prenatal therapy. When you have the fetal blood, which can be accessed through pubs, and you have done fetal hematocrit, and if it is less than 30%, it's an indication for fetal intrauterine transfusion. The transfusions are done with ORH negative type of blood crossed cross-match with the maternal serum. And multiple transfusion can be done not only in isoimmune hemolytic anemias, but these transfusion can be offered when there is severe fetal anemias secondary to parvovirus infections, or anemia secondary to fetal or it is because of twin-to-twin transfusion, or it is because of an associated sacrococcygeal teratoma and in hemoglobinopathies. In all of them, multiple transfusions can be offered in utero, and the pregnancy can be carried till as close to term as possible. And you can deliver a fairly normal baby with very good prognosis. Majority of structural cardiac which are associated with non-immune hydrops have a very poor prognosis, and many of them may not be amenable in the neonatal period. Therefore, when you definitely termination of pregnancy can be strongly advised. However, in case of fetal arrhythmias with a structurally normal heart, you can expect a resolution and you can offer fetal therapy. Intrauterine, you can administer fetal antiarrhythmic drugs, which commonly includes digoxin, furosemide, verapamil, amiodarone, etc. The delivery of drugs can be given directly to the neonate after delivery, or they can be administered antenatally, and it can be given directly to the fetus via the intraperitoneal route or intramuscular or intravenous routes during chordosynthesis. These drugs can also be administered to the mother, where following her ingestion, the drugs can reach the fetus via the transplacental route. Everyone of us has heard about fetal surgeries. These are yet not commonly available in India. So, in a few centers in India, they are offering these following interventions. The common among them are intrauterine transfusions, severe fetal anemia, then it can be a fetoscopic leisure photocoagulation, especially in twin-to-twin pregnancies. The ablation of the feeding arteries in monochorionic pregnancies. Fetal shunt placements, especially for pleural effusion can be done. Some centers even can offer exit surgeries for removal of tumors, or in the case of diaphragmatic hernias, or in the case of say maybe hydrocephalus, or all these conditions, and for removal of certain tumors, especially the pulmonary tumors, can also be practiced through exit surgery. Amniotic band and selective emulsion, not directly related to hydrops, but these are also surgeries which are offered by these centers. Despite the availability of fetal surgery and these therapies, the fetal outcome when you resort to these procedures, they cannot be guaranteed, because many of these interventions are associated with significant fetal and maternal risk and may end up in abortion. Now coming to the delivery room managements of such babies. One thumb rule is, as I've already mentioned, they should be delivered as close to term as possible. And all these fetuses should be delivered in a tertiary center where a multidisciplinary team is available for resuscitation and subsequent supportive care in a good NICU. What is the best time of delivery? Very hard to say in most other conditions. Early delivery may be unavoidable in the following conditions. One, if the fetus evaluation becomes non-reassuring. In many cases, the mother can have severe eclampsia in more than 50% of the cases, and the pregnancy may have to be terminated. Many times, she undergoes preterm labor because of associated severe polyhydramnios. So this can also sometimes be avoided by repeated amniocentesis, and you can gain more time and go as near term as possible. In the delivery room, before the child is delivered, you again submit for USG for in the lung, pericardium, or in the peritoneum. You may be able to aspirate large quantities and help in delivery of these babies. And these procedures may also help in subsequent stabilization of the baby after delivery. The team present for delivery of such babies should be good at intubation, placing umbilical lines, administration of medications, and most of these babies will need thoracocentesis and paracentesis to drain the fluid to help in stabilization of such sick babies. Almost all these babies which deliver will need an endotracheal intubation and other supportive care. In addition, there may be complications associated with prematurity, and they can have cardiorespiratory compromise. The additional difficulties associated with stabilization of these babies in the delivery room are those because many of these babies will be having hypoplastic lungs, hyaline membrane disease, pleural effusions, pulmonary edema, sepsis, perinatal depression, hypoxia, and acidosis. These add to the difficulties of stabilizing these babies in the delivery room. So in such resuscitation, it is very necessary to have an experienced neonatologist who is well versed in intubation, because this intubation can be difficult because of the fluid and pressure around the trachea, making intubation very, very difficult. So once having stabilized this baby in the delivery room, these babies are moved to NICU for further treatment. In the NICU, these babies are once again subjected to a full physical examination, to echocardiography and radiological investigations to rule out any structural malformations. The blood from these neonates is drawn for sepsis, for biochemical evaluation, and for karyotypic evaluation. The placentas of all such hydropic fetus should be sent for histology and culture. It is now time to involve the other specialists wherever necessary. For example, in cardiac conditions, the cardiologist; in a structural anomaly of the heart, the cardiothoracic surgeon; very often the pediatric surgeon to exercise the tumors and space occupying lesion in the lung. And not to forget, you should now be involving the clinical genetist. Babies will invariably need ventilator support for adequate oxygenation, and wherever necessary, the other support through inotropic agents, diuretics, blood products, albumin, and adequate administration of fluids by avoiding fluid overload and tissue edema. All this will be mandatory. I will not go into the details of all these. To conclude, I shall make the following remarks. 1. Non-immune Hydrops Fetalis is a very uncommon condition, but is a very serious disorder associated with overall poor prognosis. If the cause of non-immune hydrops cannot be determined, the perinatal mortality is very high, approximately 50% of the cases. If fetal hydrops is detected early in pregnancy with no treatable underlying cause, the prognosis is poor and therefore termination should be considered. Recurrence of hydrops in subsequent pregnancy is rather uncommon unless it is associated with isoimmunization or an inheritable disorder. The moment the woman is diagnosed with hydrops, she should immediately be referred to a feto-maternal unit where a multidisciplinary team is available, and this multidisciplinary team should involve a perinatologist, a neonatologist, a genetist, and other pediatric subspecialties as required. All of them should be involved very early in the pregnancy. Their inputs are very important regarding whether the pregnancy should be continued or should be terminated. So this psychological support and accurate information can help make these other decisions. Extensive investigations are required, but all interventions are not without potential risk both to the fetus and to the mother. But their inputs from the investigations are very helpful in making the correct decisions. Fetuses with pulmonary lesions are often associated with hypoplastic lungs, and often they are the cause of deaths in these hydropic fetuses. Fetal hydrops with the structural heart defects have very poor prognosis, almost 100% mortality. Fetal surgery, although available, it is they are available in very few centers and are applicable only to very few conditions. Like I said, in only about 20 to 30% of the cases. And wherever you do interventions, they are not without potential risk, and this risk often outweigh the benefits. When there is an in utero death or a neonatal death of an hydropic fetus, always encourage for a postmortem, because the autopsy will reveal the causes of the hydrops. This may facilitate in counseling and in prediction of recurrence in subsequent pregnancies. With these few observations, I conclude my talk. Thank you all very much.
Thank you, sir. Thank you very much for the excellent presentation. Sir.
Hello.
Yes, sir. Yes, sir.
Hello. Thank you, Arun. A very good, excellent presentation on Hydrops Fetalis. Most of the things will not be knowing. So your thing is that should be delivered at the tertiary level only where the facilities are available. How do you transport the mother with this history?
No, many times it is detected very early in pregnancy. She is fairly stable.
I mean,
sir, can we take up the discussion later, sir, after the presentation? Is it okay?
Sure.
Okay, fine.
Presentation. Okay. Kishore, sir. Dr. Gayatri, please start sharing the screen. Kishore, sir.
Arun, thank you very much for such a wonderful presentation. Thank the new norm because we could listen to you in this season Otherwise, we would have met once a year. Thank you for the wonderful presentation.
Thank you for the
Over to
invitation,
you, Prashant.
and thank you for the kind words.
Thank you, sir.
Thanks.
Thank you. Now I request our Karnataka NNF Joint Secretary, Dr. Gayatri. Over to you, Dr. Raghavendra.
Only 1 to 1 or 2 times video like audio contribution there.
Dr. Raghu?
Yeah.
Yeah, Dr.
Yeah.
Raghavendra.
Good evening. Good evening, Prashant. I like to introduce Dr. Gayatri. Gayatri, madam. She is associate professor in JJ Medical College. She is presently working as in neonatology unit in Bapuji Child Institute, and I like to invite madam for a full session. Over to Prashant.
Dr. Gayatri, please start the session. Thank you.
Thank you, Dr. Raghavendra and Dr. Prashant. I want to thank NNF Karnataka for giving me this wonderful opportunity. And I congratulate Dr. Desai sir for his wonderful presentation. And I thank my teachers and friends who guided me for this presentation. Coming to the topic proper, infant of diabetic mother. So my topic will be discussed under the following headings: introduction, incidence, risk factors and pathophysiology, maternal complications, infant of diabetic mother proper, pathophysiology, effects of fetus and neonate, management of IDM babies, and studies related. Hyperglycemia first detected at any time during pregnancy should be classified as either gestational diabetes or diabetes mellitus in pregnancy, according to WHO criteria. The World Health Organization has predicted that between 1995 and 2025, there will be 35% increase in worldwide prevalence of diabetes. Moreover, women born in Asian countries shows the highest prevalence of GDM, with up to 17% of women likely to develop GDM. Women who have GDM have at least 7-fold increase of developing type 2 diabetes mellitus in the future. This is a meta-analysis from Lancet 2009. Diabetes in pregnancy is associated with the increase in risk of fetal, neonatal, and long-term complications in the offspring. Maternal diabetes may be pregestational, that is type 1 or type 2 diabetes, diagnosed before pregnancy with a prevalence rate of approximately 1.8%, or gestational, that is diabetes diagnosed during pregnancy with a prevalence rate of approximately 7.5%. The outcome is generally related to the onset and duration of the glucose intolerance in pregnancy and severity of the mother's diabetes. Coming to the pathophysiology of gestational diabetes, as the pregnancy progresses, there is relative insulin resistance. That is, after 20 weeks of pregnancy, there is shortage of insulin. When this is tolerated, that can lead to normal pregnancy. When it is not tolerated, that can lead to gestational diabetes. The similar pathophysiology, which shows that fetoplacental hormones, that is growth hormone, cortisol, prolactin, which are needed for maintenance of pregnancy, increases as the gestation progresses. All these are anti-insulin hormones. When there is compensatory increase in insulin secretion, it leads to normal pregnancy. When there is no compensatory increase in insulin secretion, it can lead to diabetic pregnancy. So in concise, this is the chart which is showing the pathophysiology of gestational diabetes. Late pregnancy can lead to maternal hepatic glucose production to meet the increased demands of the fetus by 15 to 30%. There is also a pancreatic beta cell dysfunction, which can be due to genetics, autoimmune disorders, or chronic insulin resistance, or insulin resistance due to placental secretion of anti-insulin hormones, or a combination of glucose intolerance, hyperglycemia, and beta cell dysfunction. common risk factors for developing gestational diabetes mellitus are prior GDM, obesity, acanthosis nigricans, and family history of diabetes. So what are the recommendations from different organizations? Various organizations like American Diabetes Association, ACOG, WHO, and International Association of Diabetes and Pregnancy Study Group has forwarded cut-off values after a glucose tolerance test using either 75 grams or 100 grams of glucose and determining the fasting levels, which range from 92 to 126, and 1 hour and 2 hour glucose concentrations, which range from 180 to 190, and 2 hours, which range from 140 to 165. So what do we follow in India? So according to the recent guidelines by National Health Mission, has put forward these guidelines for universal testing of GDM. The pregnant woman comes for the first antenatal visits, that is for her first antenatal visit in her first trimester, 75 grams of oral glucose is given, and blood sugar is checked after 2 hours. If it is more than 140, considered as GDM and managed according to the guidelines. If it is less than 140, the repeat testing done is at between 24 to 28 weeks. Positive, then go for that is more than 140 milligrams per deciliter, manage as GDM. Negative, consider it as a normal pregnancy. So what are the maternal complications? Women with pre-existing diabetes have a risk of worsening of pre-existing long-term complications such as retinopathy and decline in glomerular filtration rate. There is also higher risk of hypertension, cardiovascular diseases, and infection in the population. This picture summarizes the complications like preeclampsia, polyhydramnios, prolonged labor, obstructed labor, cesarean section, PPHL, and infections. Coming to modified White's classification. This is modified White's classification, which is put forward by Priscilla White in 1959 to estimate the risk of perinatal wastage during the pregnancy. And the complications can be predicted by various maternal factors, such as disease duration, age of onset, and presence or absence of vascular disease. In 1980, the ACOG has revised this classification, and as we see this between the classes of A, B, C, macrosomic and LGA babies are expected. Between D and F, between between D and F, we can expect SGA or IUGA babies. Coming to our topic proper, that is infant of diabetic mother. The definition being an infant that is born to mother who persistently had high glucose blood levels during pregnancy. Any offspring of a gestational or insulin-dependent diabetic mother. Coming to the Pedersen's hypothesis, this was put forward in 1954, around almost 70 years ago, by an epidemiologist called Jorgen Pedersen. Hyperglycemia in pregnant women might lead to hyperglycemia in their fetuses, causing complications in infancy and later life. So once there is increased glucose levels in the mother, it can lead to fetal hyperglycemia, which can lead to congenital anomalies periconceptually, followed by decreased early growth between 0 to 20 weeks. And when there is fetal hyperinsulinemia, as the high glucose levels in the mother stimulates the fetal pancreas, which leads to hyperinsulinemia, can lead to early neonatal hypoglycemia and other complications. A combination of Fetal hyperglycemia and hyperinsulinemia can lead to fetal macrosomia around more than 20 weeks of gestation, and macrosomia related complications like birth asphyxia, cardiomyopathy, TPN. Fetal hypoxia can lead on to polycythemia, iron abnormalities, stroke, renal vein thrombosis, and later on poor neurodevelopmental outcome. Coming to poor glycemic control in pregnant diabetic women, maternal hyperglycemia, the first trimester leads to, that is the major trimester where the fetal organogenesis happens, can lead to major birth defects, spontaneous abortions. Maternal hyperglycemia in the second and third trimesters results in hyperinsulinemia and macrosomia. Here it's a very well depictive and informative chart which shows that as the HbA1c level increases in the mother, there is increased risk of major congenital malformations. Until 9 HbA1c, the risk is very less. Once the HbA1c crosses around 9.9, the risk has been multiplied by 3 times. Here, after 10 HbA1c, almost the risk of malformations is around 23.5%. Coming to transfer of macronutrients from mother to the fetus via placenta, glucose is the major macronutrient which is transferred by carrier-mediated diffusions through glutamate receptors, and proteins, mainly essential branched-chain amino acids, diffuse rapidly, whereas neutral chain amino acids diffuse slowly, and free fatty acids go through a gradient-dependent diffusion. Coming to maternal and fetal glucose gradient-based transfer, maternal glucose is transferred to the fetus across the placenta down a concentration gradient. It is determined by both maternal and fetal glucose levels. It goes from the higher concentration to the lower concentration, and there will be simultaneously increased insulin secretion. When there is diabetic pregnancy or high maternal glucose levels, the gradient is very steep, which increases the fetal insulin secretion, leading on to fetal hyperinsulinemia, then which lowers the fetal glucose levels and further steepens the gradient. You can see the dotted line. The fetal hyperinsulinemia stimulates triacylglycerol formation, which leads to excessive deposition of the fetal adipose tissue, which is one of the major risk factors contributing to macrosomic babies. Coming to effect of maternal diabetes on the fetus. So what are the effects of maternal diabetes on the fetus? First, regarding the growth aspect, in the first half of pregnancy, the fetus is exposed primarily to hyperglycemia, which without secondary hyperinsulinemia results in slowing of fetal growth. During the second half of pregnancy, hypertrophic islet cells responds to hyperglycemia with an increase in insulin production. This potent combination of hyperinsulinemia, which is a major anabolic hormone, and hyperglycemia, a major anabolic fuel, results in a cascade of third trimester events, which results in increase in the fat stores in the fetus. Coming to the glucose metabolism, maternal diabetes mellitus during pregnancy is characterized by glucose intolerance and insulin absence or resistance. Mothers with glucose intolerance are frequently treated with exogenous insulin to maintain normal glycemia, whereas maternal glucose travels the human placenta very easily, whereas exogenously derived insulin or maternal insulin cannot traverse the placenta. The fetus becomes hyperglycemic and stimulates islet cell production and insulin production, which can lead to periods of hyper and hypoglycemic events in the fetus, which is both are dangerous, both hyperglycemic and hypoglycemic episodes. Coming to fetal oxygenation, chronic fetal hyperglycemia and hyperinsulinemia affect the fetal basal metabolic rate with secondary effects on fetal oxygenation and erythropoiesis. Fetal hyperglycemia and insulinemia increase fetal total body oxygen consumption by as much as 30% and in a relatively oxygen limited environment. Although fetuses increase its rate of substrate uptake and oxygenation, there is a relative fetal hypoxemia which contributes to higher incidence of fetal deaths, metabolic acidosis, and erythropoiesis. And it also leads to alteration in fetal iron distribution. In humans, this severity of polycythemia is related directly to the lack of maternal glycemic controls. Coming to iron metabolism, as the fetal red cell mass expands up to around 30%, the need for fetal iron expands are also parallelly increased. This is compensated by the diabetic placenta by increased iron expression in the form of transparent receptors on the maternal placental surface. The resultant redistribution of iron supports the red cell mass, which becomes polycythemic at the expense of the other developing organs like heart and brain. Coming to preparation to the extrauterine life, fetal hyperinsulinemia is also likely responsible for delayed functional maturation of different organs. It has a blunting of effect on the cortisol surge before delivery, which may contribute to the higher incidence of RDS and have an effect on the bilirubin metabolism. Coming to the neonatal complications, the major complications being the prematurity, perinatal asphyxia, respiratory distress, metabolic complications, polycythemia, hyperbilirubinemia, and cardiomyopathy, which we'll be discussing one by one in the next subsequent slides. These are the few pictures that I'm sharing of our inborns. This is a baby with around 4 kgs macrosomic baby born to an infant of diabetic mother who was on oral hypoglycemic agent, presented for us with TTNB, settled with 24 hours of oxygen therapy. And this is another child, 4.5 kgs macrosomic baby, presented us with again TTNB and with symptomatic 2 episodes of hypoglycemia. And this is a comparison between 4.5 kg and 1.5 kg baby, LGA and SGA. So what is the effect of macrosomia on the maternal and fetal components? So maternal components leads to perineal injury, instrumental deliveries, PPH, prolonged hospital admissions. Fetal short-term being prolonged labor, hypoxia, low abgas, NHO admissions, and perinatal mortalities. Long-term overweight, obesity, metabolic syndromes, diabetes, type 1 or type 2, and certain cancers. So it should be predicted, and guided obstetric management should be done to avoid or reduce the adverse outcomes. So what are the macrosomia related complications and how are they managed? Clavicular, humeral, and femur fractures, all of them are related to birth injuries. Brachial plexus injuries like Erb's palsy, Klumpke's palsy, and other spinal cord injuries are predicted in these pregnancies. And so carefully be managed. If happens, orthopedic management and rehabilitation should be done. So this is a case of Erb's palsy. And this is a case of facial injury presenting as asymmetric crying faces. This is the X-ray of a neonate showing right-sided clavicular fracture. Coming to the metabolic morbidities, hypoglycemia being the major metabolic morbidity, presents with lethargic uterine apnea, hypothermia. If asymptomatic, breastfeeding should be encouraged and glucose should be monitored. Symptomatic, boluses 10% dextrose is given. And we have a protocol from our own aims which shows that hypoglycemia less than 40 asymptomatic, between 20 to 40 we given a trial of feeds and then monitored. More than 40 frequent feeds to be done. Less than 40 you should be going to a protocol of managing asymptomatic hypoglycemia by starting giving a bolus of 2 ml per kg, 10% dextrose followed by your IV glucose at the rate of 6 mg per kg per minute. And if it is more than 50, the IV fluids are continued with monitoring continuously 6 hourly and slowly cutting down on the infusion rate. If it is less than 50, increase the infusion rate. And if the infusion rate is more than 12 mg per kg, you need to think of the other causes. Hypocalcemia presents again with irritability for the cutoff of hypoglycemia, operational threshold is taken as less than 40. For hypocalcemia, which presents with similar symptoms of irritability, for feeling, lethargy, jitteriness, again we do follow a protocol. Total serum calcium less than 7 or iron less than 4 symptomatic, go with a bolus of 2 ml per kg of calcium gluconate followed by 80 mg per kg for 48 hours, followed by 40 mg per kg for the next 24 hours, and then slowly cut down and stop. Asymptomatic, you can go for a IV calcium gluconate, same protocol, 80 mg per kg for 48 hours and 40 mg per kg for the next 24 hours. Then monitor and stop. No need of bolus in asymptomatic cases. Hypomagnesemia, another dreaded complication where presence as jitteriness, apnea, and feeling. When hypocalcemia is ruled out and hypoglycemia is ruled out, the third option to be considered is hypomagnesemia, where 2 doses of 0.2 ml per kg of 50% max sulfate is given for large deep iron followed by a maintenance dose. Coming to the respiratory morbidities, the most common respiratory morbidity being respiratory distress syndrome, relative surfactant deficiency because of the blunting effect of the cortisol in the maturation of lungs. Usually treated by oxygen therapy in mild cases. Moderate to severe cases need surfactant with or without ventilation. Transient tachypnea of newborn macrosomic babies, incomplete drainage of lung fluids can lead to increased distress and worsening downwards. Needs to be treated with oxygen therapy and monitored should be done regularly. This is a case of X-ray of an infant of diabetic mother with worsening RDS right from the birth to the 12 hours of life. And this is a case of TTNV, which in fact improved with the oxygen therapy. This is taken at birth and this X-ray is taken after 24 hours. Coming to the cardiac morbidities, asymmetrical septal hypertrophy being the commonest, which can lead to mimic as hypertrophic obstructive cardiomyopathy treated with beta blockers and septal myomectomies can be done in severe cases. And the other common cardiac morbidities being TGA, DORB, HLH, and VST, for which surgical correction need to be done. This is an X-ray showing septal hypertrophy presenting as cardiomegaly. The common hematological problems being polycythemia, hematocrit more than 65%. The pathophysiology already we discussed because of the hypoxia and increased erythropoiesis. The problem we do follow is more than 65% confirmed with venous hematocrit, exclude dehydration and weight loss. Symptomatic, go for partial exchange transfusion. Asymptomatic between 65 to 70 monitor, 70 to 75 consider hydration, more than 75 go ahead with partial exchange transfusion. Hyperbilirubinemia, go ahead with phototherapy following the charts, Bhutani charts, and double volume exchange transfusion if required and falls in the exchange zone. Coming to the orthopedic problems, musculoskeletal problems, fodder regression syndrome, almost synonymous with the infant of diabetic mother. Here we can see almost absence of the lumbar bones and the similar MRI picture showing lumbosacral hypoplasia. And this is a case of elbow and knee dislocation in an infant of diabetic mother, and this is where we see hypoplastic femurs. Coming to gastrointestinal anomalies, the most common gastrointestinal anomalies are duodenal atresia. Here we see double bubble appearance, and this is the lazy left colon syndrome, or what we call small left colon syndrome. High anorectal anomalies are also very common. Here this is a case of rectovesical fistula. CNS anomalies commonly being neural tube defects. This is a case of anencephaly, which is detected in the 20-week antenatal ultrasound. This is a case of meningomyelocele, and this is the CT showing holoprosencephaly. What are the MRI changes as a result of hypoglycemic insult? We see low attenuation of the white matter in parietal and occipital lobes. We had an experience of our own inborn who presented on day 3 of life with seizures. When sugars were documented, they were less than 40. And when we started IV fluids and increased on the oral feeds, and an MRI was taken on the day 7, which showed both hypoxic changes and metabolic changes. And this is the common metabolic changes we see on the MRI, low attenuation of white matter in basically parietal and occipital lobes. So what are the long-term sequelae? IDMs are increased risks for delayed motor and cognitive development that manifest in later life. The long-term delays can be a function of either acute perinatal event, that is birth asphyxia, or alterations in the brain damage from the adverse intrauterine environment characterized by hypoxemia, hyperglycemia, acidosis, and iron deficiency. Infants who experience seizures secondary to metabolic derangements like hypoglycemia, hypocalcemia carry a 10 to 15% risk of subsequent seizures and neurodevelopmental anomalies. 80% of infants who suffer seizures from HIV exhibit developmental delays. So, and other long-term sequelae are fetal origin of adult diseases. The hyperglycemic environment is a potent teratogen, which can lead to fetal death, spontaneous abortions, and fetal anomalies, along with neural tube defects. Fetal programming is done at this stage, which can lead to childhood and adulthood neurological diseases, obesity, motor impairment, low intellectual verbal quotient, psychosocial problems, psychiatric disorders, and neurodegeneration. This intrauterine hyperglycemia is a pro-oxidant state, can lead to oxidative stress, inflammation, epigenetic programming, leading to endothelial dysfunction and adult onset, fetal onset of adult diseases. That's Barker's hypothesis, atherosclerosis, and hypertension. This is a very beautiful slide which summarizes the whole presentation of infant of diabetic mother. Maternal hyperglycemia at 0 to 20 weeks, leading to hyperglycemia, major congenital malformations like situs, CGA, DRV, neural tube defects, renal agencies, GI atresia, a combination of hyperinsulinemia, hyperglycemia with increased anabolism leads to macrosomia and hypoxia. After delivery, loss of maternal calcium, magnesium from renal insufficiency can lead to delayed neonatal PTH control, leading on to hypocalcemia, hypomagnesemia, and other metabolic abnormalities in the first 24 to 72 hours. Insulin inhibits cortisol effects, leading to RDS, loss of maternal glucose, leading to hypoglycemia, decreased GI mortality, which can lead to small left colon syndrome. Traumatic birth can lead to brachial plexus injuries, on which we already discussed, birth asphyxia, and cardiomyopathy can because of septal hypertrophies, and increased cord erythropoietin and decreased cord ferritin, which manifests as polycythemia and hyperviscosity, and altered iron distribution, all leading to poor neurodevelopmental outcome. So some of the research articles I'll be sharing. This is a study done in our own AIMS on 263 pregnant women, diabetic mothers, to know the perinatal outcome. 225 were born to IGDM mothers and 38 for IDM with established diabetes. So the major morbidity patterns in this group were hyperbilirubinemia, polycythemia, and hypoglycemia. In this group, the similar morbidities were observed, like major being 16% hypoglycemia, 8% being hyperbilirubinemia, and birth asphyxia also is important in both the groups. And the stillbirths were encountered in both groups, along with early neonatal deaths with a significant p-value. And this is a study done in Tamil Nadu, South India, on infants, 65 infants, 48 being born to gestational diabetic mothers, and 17 for overt diabetes. The occurrence of morbidities and mortalities were significant in GDM mothers compared to the overt diabetes, who has a good glycemic control. So the common morbidities observed were polycythemia, hypobilirubinemia, hypoglycemia. This is a study which is done in our own state from Tumkur Medical College, a prospective case control study with 1 year, which is done for a year on 1,000 pregnancies, with a group division of non-GDM with 925 and GDM 75. The major problems associated were RDS 14%, followed by hypoglycemia and polycythemia and other metabolic abnormalities with a significant p-value. Coming to management of these babies, so prenatally maternal ultrasound is done for the size and biophysical profile, and HbA1c is monitored. Delivery room, do physical examination for distress and rule out congenital anomalies. Postnatally, glucose monitoring is done at 2, 6, 12, 24, 48, and 72 hours. And if required symptomatic, it's done more oftenly. Calcium 6, 24, 48 hours. Hematocrit is monitored both at 4 hours of life and later 24 hours. Platelets every 24 hours. Bilirubin based on clinical assessment. Immediate management is the most threatening problem is hypoglycemia, seen in 50% of macrosomic infants and 5 to 15% of neonates with optimally controlled gestational diabetes. A bolus is given and the protocol is followed, which we have already discussed. Encourage breastfeeding, which is very important. Examine the infant for congenital anomalies. Postpartum follow. In women with gestational diabetes, tight control, the tight control is relaxed for those on insulin. 1/3 or to half of end pregnancy, insulin dosage is usually recommended. In gestational diabetes, treatment in the postpartum will need to be individualized based on the consultation with the endocrinologist. Those on diet control or on oral hypoglycemic agents during pregnancy usually do not need any treatment in the postpartum period. Women with gestational diabetes should be asked to have their blood glucose levels checked 6 weeks after delivery, as they may be reclassified as type 2 diabetes and will need continued treatment. So what are the future risks? 75 grams OGTT should be done for all women with GDM 6 to 12 weeks after delivery. About 75 to 80% are normal glycemic and 20% have impaired glucose tolerance. The risk of developing type 2 diabetes is 3.7% at 6 months, 4.9% at 15 months, and 35 to 60% develop diabetes over the next 10 years. The risk of recurrence of GDM is 30 to 69%. Risk of developing diabetes mellitus in offspring. If the father has type 1 diabetes, the risk is 6 to 8%. It is 2 to 5% if the mother has type 1 diabetes and 10 to 25% if both are affected. In type 2 diabetes, if single parent is diabetic, the risk is as follows. 14% if the parent was diagnosed less than 50 years, 8% if diagnosed more than 50 years. The risk is 50 to 60% if both are affected. A recent meta-analysis, which is published in PLOS One journal, includes a total of 9 studies from 72 lakh participants, have shown that offsprings of diabetic mothers concluded that they were at higher risk of attention deficit hyperactivity disorder. These are some of the studies which were published, the long-term outcome of infants of diabetic mother. A systematic review done by Orney et al. Has shown that pre-gestational or gestational diabetes may adversely affect the attention span and motor functions of the offspring, but not their cognitive ability. Whereas a systematic review done by Eden et al. Has shown that maternal diabetes mellitus during pregnancy was negatively associated with offspring's cognitive development. A meta-analysis done by Mang et al. Has shown that GDM babies were associated with increased risk of autism in future. Coming to the conclusions, with modern management, fewer morbidities can be expected in infants of diabetic mothers. Those infants born to women with IDM remain at risk for hypoglycemia, which can be treated in 1/2 of the cases by enteral feeding alone. The majority of cases of RDS are mild and require short admission through special care nurseries. Optimal care of infants of diabetic mother is based on prevention, early recognition, and treatment of common conditions. Severe congenital malformations, significant prematurity, RDS, recurrent hypoglycemic episodes, and asymptomatic infants of women with advanced IDM should be admitted to special care nurseries. Breastfeeding among women with GDM should be encouraged. Follow to be done for high-risk IDM babies. This is one of our IDM baby which came for follow. The child is thriving well. She was initially admitted in our NICU for hypoglycemic episodes. So coming to the last two summary slides of my presentation, there are a lot of environmental risk factors, socioeconomic factors, and individual risk factors which can lead to gestational diabetes with short-term complications for maternal and neonates, and delivery-related complications, and long-term complications both for maternal, mother and child. So coming to life course approach to diabetes mellitus, mainly we'll be concentrating on this aspect. Pregnancy, optimize maternal nutrition, avoid maternal smoking, avoid low birth weights, reduce stress, screening for gestational diabetes, treatment of gestational diabetes, avoid excessive weight gain during pregnancy, avoid macrosomia. This is a cycle, vicious cycle, which impacts generations together. Thank you for your kind attention and patient hearing. Any questions?
Thank you, Dr. Gayatri. It was a most comprehensive and very clear presentation about the infant of diabetic mother. I request Dr. Ashwit Shriyan,
yes, sir,
to moderate the session, and there are a lot of questions which have come. Right. Over to you.
Good. Speakers, Dr. Arun.
Yes.
And Dr. Gayatri Madam for having shared the valuable knowledge. We are looking at two different kind of problems in these topics. One very much common which we come across, and very much. So right now, let us take first the questions with Dr. Arun Kumar sir. So first question to you. One of our fellows would like to know, sir, is there any role of exchange transfusion in your non-immune hydrops, sir?
Exchange transfusion in non-immune hydrops?
Yes.
So what would be the etiology for exchange transfusion?
So probably if there is anemia per se along with that.
No, for anemia we give only ORS negative blood to the fetus. It can be given in utero or
yes,
after the baby has been delivered. But
okay,
I have not come across any reason for exchange transfusion.
Okay,
Here,
sir.
in non-immune hydrops, it is a there is no hemolysis as taking place.
Sir, how much blood is required, sir, or amount of fluid that needs to be given for the anemia, sir?
No, this is a very complex question because it varies with the gestation, it will vary with the weight of the baby, and it will vary with the severity of anemia the fetus has. So there are many references and there are many formulas. We'll have to apply those formulas. So I cannot tell you the exact volume. It will vary with the weight and gestation of the baby.
Okay.
And you'll have to apply the formula.
Sir, how much fluid? There will be fluid accumulation in the abdomen and the thorax. Are there any guidelines regarding how much fluid we can remove or how much can be drawn out from the baby?
All that I have come across is that you have to be very careful not to go for fluid overload and result in further worsening of the hydropic condition of the newborn fetus. There are no definite guidelines. Definitely, we will exercise fluid restriction to avoid fluid overload.
It's regarding removal, sir. Removal of fluid from the abdomen or pleural space.
No, that is one only. This is practiced in the before delivery, if the fetus is showing presence of, say, fluid in the lung, in the pericardium, or in the swan, you try to get out as much fluid as possible, and that will assist in the delivery and also in the resuscitation in the delivery room. There are no exact volumes. As much as possible, which is accessible, that you can remove.
Okay. Sir, you mentioned regarding post-mortem for the baby.
Yes.
Sir, what exact?
Sorry, your question is not audible.
For the post-mortem,
yes,
are we supposed to ask for any specific test or anything else organ-wise? Are we supposed to look for if we are looking for a diagnosis of non-immune hydrops?
So the postmortem is done for structural anomalies to pick up. Then also you'll be looking for evidence of chromosomal anomalies. You'll be looking at the heart, looking at the various organs. Then you can do again for karyotyping, you can do the enzyme studies. So try to come to a particular cause. Mainly we're looking at whether recurrence can occur in subsequent pregnancies. And if the chances are less, then accordingly the couple can be advised regarding the possibility of recurrence in subsequent pregnancies. So examination of the placenta, then postmortem examination of the fetus becomes very important. And the genetic evaluation especially is very important. Those which are maybe associated with chromosomal anomalies.
So last question to you, sir. Two issues. One thing is cystic hygroma, another is chylothorax.
Yes.
Anything specifically regarding these kind of babies?
Cystic hygromas commonly with Noonan and Turner syndrome. And these are large space occupying lesions. And they are the ones which can lead to obstruction of the venous return. And lymphatic flow is also obstructed. And that leads to hydrops. So many of them are associated with chromosomal anomalies. And again, if it is associated with chromosomal anomalies, the prognosis is not good.
Okay, sir. Regarding chylothorax, sir, how do we go ahead manage anything regarding that?
In utero chylothorax, antenatally, again, you can aspirate. Then in utero, you can place stents, the fluoroamniotic stents, and they will allow the lung to grow. And therefore, this fetus can be avoided the complication of hypoplastic lungs.
Any role for those sclerosants? It can be administered postnatal.
Has not specifically come across, but somebody can just add. I'm not very sure. And these are very rare conditions because in our personal experiences is not very much, and it's very rare that we come across the hydrops in our day-to-day practice.
Right, sir. Right.
So very difficult to give definitive answers.
Thank you, sir. One more as a last one. What is the reason for anasarca?
Anasarca is basically fluid collection. Analyze.
That is hypoalbuminemia.
Sorry. Yeah, I can't hear you.
Sir, anasarca, that is hypoalbuminemia causing anasarca, sir. What is the reason for it? Specific anything?
It's a decrease in oncotic pressure. And because of decrease in oncotic pressure, fluid escapes from the intravascular space to the interstitial space and accumulates there, leading to hydrops.
Okay, any preventive measures for future pregnancies, sir, that the parents need to take care to prevent non-immune hydrops? Anything that can be done?
That's what I told. Recurrence is uncommon in majority of the cases of non-immune hydrops. Only if they are associated with inheritable metabolic disorders, or say they are associated with, say, hemoglobinopathies or some such conditions, then the chances of recurrence can be there. Otherwise, if they're not associated associated with inherent metabolic disorders, the chances of recurrence is very less. And of course, we'll be looking at chromosomal disorders. If chromosomal disorders, we'll be evaluating both the parents for carrier status. And if that is there, then the chances of recurrence is there.
Questions for Dr. Gayatri, madam?
Yes.
Yeah. Now, since this being a benign condition mostly, what is the indication for propranolol or septal myomectomy in asymmetric septal hypertrophy in IDM babies?
When they are presenting with cardiomegaly and decreased cardiac dysfunctions, we can give a trial of at least propranolol, which is easily available. Which is refractory to the medical therapies, of course, we need to treat the asymmetrical hypertrophy by doing a myomectomy.
Is there a difference in the effect on the infant?
Sorry, sir, your voice is breaking.
Has
your voice...
gestational diabetes or pre-gestational diabetes?
I can't hear your question. Your voice is breaking.
In the effect on the infant, if mother has gestational diabetes. Can you hear me now?
No, I can't hear you. Your voice is breaking.
Can you hear me?
Yeah, now I can hear.
Okay. Is there a difference in the effect on the infant if mother has gestational diabetes or pre-gestational diabetes?
Yeah, definitely there will be effect because if that again depends on her glucose concentrations and how well is her glycemic status is controlled, and of course your HbA1c levels.
No. What exact difference are we going to look
at? That again difference. If she is IDM, that is pregnant before pregnancy, if she has diabetes. And how that basically depends on how well her diabetes is controlled and whether she's on insulin or oral hypoglycemic. And some studies have shown that there is no much major difference in the morbidities of both gestational diabetes or overt diabetes. That basically depends on how well her glycemic status is controlled. But both are teratogens, high glucose concentration. Both are having teratogenic effect.
You mentioned that we need to monitor the platelet counts in the infant diabetes baby. So, what is the reason exactly it should be monitored?
Your voice is breaking. You mean why?
What is the reason? What is the reason that it should be monitored? The platelet count in infant or diabetics.
Platelets are not routinely done, but just as a baseline count, one platelet count is documented. If there are associated comorbidities like birth asphyxias, and if the mother is having a pre-added pre-eclampsia or eclampsia along with comorbid conditions along with gestational diabetes, in those conditions, obviously there will be a platelet fall. So as a baseline count, one platelet count should be documented.
Okay. Now we like to take.
Hello, I can hear your question.
We are waiting for the audience to question. Any raise of hands we have? Anybody would like to ask any questions?
I think Dr. Naresh has raised his hand. Dr. Naresh?
Yes.
Yeah, please ask.
Myself, Dr. Naresh Prasad. My question regarding the what specific advice to be given to the parents of the diabetic mother regarding the outcome or the later on follow-up of these children? Any special?
Your voice is not clear, sir.
Any special education or any specific advice given to the parents regarding the outcome of these type of children?
If the glycemic status of the mother is well controlled and the baby falls in the appropriate gestational age and appropriate weight category, and with no associated comorbidities, fairly the prognosis is good.
Do the children will remain obese in the later part of the life?
That's what, if there is no associated comorbidities like macrosomic babies or associated cardiorespiratory morbidities or no NICU stays, well-maintained glucose levels, then I think there is no any special precautions to be taken, and they can be managed as a regular babies only, except for a mild risk of babies getting type 1 or type 2 diabetes in future, which incidences I have already mentioned in the slides.
Thank you, Dr. Naredi.
Yeah, we do have one more question. Yeah. Do we need to check the calcium on the first day itself, as the nadir of calcium values changes between second to third day?
So, if the baby is not symptomatic, and if it doesn't fall in the high risk category, it's not required to check on a daily basis or this one. If it falls in appropriate weight category, no morbidities and no manifestations which we think of hypocalcemia, it is not regularly done on daily basis or protocol basis.
Any further raise of hands? Anyone? Questions?
I didn't see it was somebody. That's it.
None, sir.
One second. Just yeah, I think there are no questions. We'll wait for a few seconds. Like somebody has raised their hands. One second. Dr. Trivikram Reddy. Dr. Trivikram Reddy. Ashwit, can you? Yeah. Dr. Trivikram Reddy, please go ahead. Yeah, good evening.
If mother is under control on diet modification or she is on oral hypoglycemic, should we consider that baby as IDM and to monitor, sir?
Once, according to your latest NHM guidelines, which have put in one of the slide, if she is having post glucose tolerance tests after 2 hours, if the blood glucose is monitored more than 140, we need to consider has a diabetes pregnancy, GDM mother, gestational diabetic mother. And if though she is on diet modification or oral hypoglycemics, her baby is considered as infant of diabetic mother. And rest of the morbidities we need to assess after the birth.
Dr. Guru Prasad sir has raised hands. Yeah, one second. Yeah, just unmute him. Yes, sir.
Yeah, good evening, Prashant. Yeah,
Yes,
sorry. Dr. Arun and Gayatri, wonderful presentation.
Thank you,
Especially,
Professor.
Dr. Arun, I think you made this such a complex topic so simple, and the take-home message, you made it very clear that it is non-immune hydrops, not the immune hydrops that we are interested. As you rightly said, there are all case reports in our country. Not that they are not existing, because we have limitations of evaluating these aborted fetuses and stillbirths, but some is accumulating. Wonderful presentation. I'm proud that Dr. Gayatri is working with me, my junior Gayatri. You did a great job.
Thank you.
And I was in another meeting. I was just finished. I thought it would be unfair if I don't speak to you personally. Very well done presentations and very informative talks. Prashant, thank you very much.
Thank you, Dr. Guru Prasad, for your kind words.
Thank you, sir. Thank you, sir. So I think there are no more questions. Sir, Quadrish, sir, yeah, you had some questions.
I'm very thankful for Dr. Arun and Dr. Gayatri for wonderful presentation on different things. And I got a question to Gayatri.
Yes, sir.
Can you hear me now?
Yes, sir. Yes, sir. I can hear you.
In an assessment of gestational diabetic, if it is a multiple pregnancy,
Yes, sir.
Whether the history, delivery, and presentation will be the same or a different one?
Sir, again, multiple gestations, there can be same morbidities as singleton pregnancies. Only thing is, macrosomic babies are very rarely seen in multiple gestational babies, but the morbidities we can expect the same, apart from your macrosomic complications.
Okay, thank you, ma'am.
Thank you, sir.
Thank you, Prashant.
Thank you, sir. Thank you, sir. Dr. Dinakar, sir. Dr. Dinakar, sir. Dr. Dinakar, sir.
Prashant.
Yes, sir.
So, Dr. Shriyam, Prashant.
Yes, yes, sir. Yes, sir. Yes, sir. We can hear you. Please go ahead, sir.
All the talks were very good, very informative, taken well. Y3 is excellent as usual. Sir, you were very calm, composed. You have covered everything. Sir, one small question for Arun
Yes,
Kumar
please.
Desai, sir. Sir,
Yes,
can
please.
I ask, sir? It is just, I'm asking. Suppose if there is a anemia picture with Hydrops Fetalis.
Yes.
Anemia picture is there, Hydrops Fetalis is there because already it's a volume overload is there, abdominal fluid is there, so thoracic fluid is there, pleural effusion is there, there is pulmonary edema is there, we have ventilated and we have put UVC. Is there any chance can we do, because I cannot overload this thing, I cannot give immediately albumin, I know that, can we do exchange transfusion, double volume exchange transfusion? Is there any role in Hydrops Fetalis, sir?
No, here what happens before you undertake normally exchange transfusion, first you'll have to bring up the hemoglobin. You will have to bring up the hemoglobin by giving pack cells.
Sir?
You'll have to bring up the hemoglobin before you can undertake exchange transfusion. Here you're talking about isoimmune Hydrops Fetalis, isn't it?
Yes, sir. Isoimmune, whichever the condition, because usually we now we are not coming across much like that because of isoimmune, but we used to do those times. Now I am not coming across since 14 years. Those times we used to do for Hydrops Fetalis, if the anemia is there, partial volume, I mean not partial, exchange transfusion, double volume exchange transfusion we used to do, because we don't want to do any immunoglobulin, sorry, what is it, albumin, we never used to give. With that, in that condition, babies used to improve. That is the reason I'm asking, sir.
Please tell me once again what you are saying. In non-immune Hydrops?
Non-immune. No, immune Hydrops, not non-immune Hydrops, sir. Immune Hydrops, like RH incompatibility. Or parva infection was there. But I have never come across parva infection with low hemoglobin. We have come across with RH incompatibility with severe this thing. In that condition, we used to do the partial, not partial, double volume exchange transfusion after the delivery.
No, if the hemoglobin is very low, the advice is always first you bring up the hemoglobin and then go for a double volume exchange transfusion.
Okay, sir. Okay, sir. Okay.
Otherwise, the risk of you will increase the risk of morbidity and mortality, especially mortality.
Okay, sir. Okay. Dr. Gayatri?
Yes, sir.
Very nice topic. Excellent, really excellent. Okay, and your topic, you have taken it nicely. So HB1AC will tell you whether how much congenital malformation will be there, what all the things.
Sir.
So you have told that one, very good. And even platelets you have, because in your slide it was showing as if we should do, but later you have told us very good. So it has to be done basic ones. At least everybody is doing it. Later, if it is necessary, we will follow up. Yes. And even why hypocalcemia will be low, you told. Why hypomagnesemia later, that is also excellent topic. IDM mother. But suppose, just I am asking, anybody here, even Sir Arun Kumar Desai, sir, you are so senior. Have you any time, and I think so, Dr. Guru Prasad sir is also there, are any seniors here who are listening? Because I never come across anything like that with septal hypertrophy going for failure. Because many seniors might have seen it. Sir, are you in that their emergency situation? Have you people really used propranolol, or you used any other drug like vasopressin? Sir, anybody here, whoever listening, please can raise the hands, or if you know anything, you can answer.
Yeah, Dinakar, Guru Prasad here. Good evening.
Sir, please, sir, please.
Number one, regarding your first question, which you asked Dr. Arun Desai,
Sir.
any fetal anemia, the principle of management is packed cell transfusion.
Sir.
Though there are case reports in the history that they have done partial and exchange transfusion, the current guidelines very clearly say whatever is the cause of anemia, you have to cope up, try to improve the hemoglobin status by giving packed cell transfusion. Probably you practice exchange transfusion only ex utero. And regarding second point, asymmetric septal hypertrophy, these are rather studied in book. We didn't had any issues. We have not lost any child because of such significant cardiovascular morbidities. These are all very benign entities which revert back to normal on their own. As you rightly said, occasionally there will be need for some vasopressors and those things. Somebody raised a question, septectomy, septal myomectomy, all that. I think that's the way the fellow or a resident will look. These conditions are self-limiting, and over time they will outgrow. Sequential X-rays, echocardiograph findings have very clearly shown by 3 to 6 months, cardiac anatomy will get back to normal. They are not left with any long-term cardiovascular morbidities otherwise. Dr. Arun can add on if there is anything.
Yeah. Hello, good evening. I'm Kishore here.
Good evening.
Good evening. Yeah, I think Guru is correct. See, we have studied all these things in the past, and obstetricians all around the world have become very aggressive in managing the infant of diabetic, basically gestational diabetes. So most of the infant of diabetic mothers born these days will not have those sort of if they undiagnosed diabetes, and even IUDs are looked at with the idea. Anyway, before I finish, thank you for a wonderful lecture.
Sir.
I think we heard so much about you from others, especially group. Thank you for the nice lecture. Good evening, everyone.
Prashant, over to you.
Yeah. Thank you very much. Thank you, Dr. Arun sir, Dr. Gayatri, Dr. Shriyan, and Dr. Guru Prasad sir, Kishore sir, and all the participants who have participated today. It was wonderful piece of information. And
what about tomorrow's class, day after tomorrow class, please?
Yes, sir. Yes, sir. So this has already been recorded. It is available in Facebook page. Please send a request. We'll approve it in the National Unit from Karnataka chapter. So we have the upcoming class on Thursday that will be on neonatal hyperbilirubinemia, and management, both direct and indirect. So don't miss Dr. Siddharth and Dr. Giridhar will be taking the session. We'll catch up again after tomorrow, same time, 5 o'clock. Thank you very much for joining. Thanks all the participants, all the speakers, and for all the support. Thank you.